This is Dr. Banerjee presenting the Excellence in Peripheral Artery Disease Thrombin Receptor Antagonist Intervention in Claudication Evaluation Study, or the XLPAD TRACE clinical trial. Today in this session, we will go over study protocol training and good clinical practice requirements for the study briefly. Let's start with the study protocol. As you may all know, that antiplatelet agents have demonstrated a modest improvement in claudication-free walking distance. However, these effects have not been replicated in rigorously conducted randomized clinical trials. Clopidogrel or Plavix has not been shown to be superior to aspirin alone in improving walking distance in patients presenting with intermittent claudication. However, newer drugs, which are protease activated receptor 1 or PAR1 blocking agents, which is Vorapaxar, has recently been shown to reduce the need for revascularization in patients with PAD on background antiplatelet therapy. However, there has been a signal for increased moderate or severe bleeding. So the rationale and hypothesis for this trial are as follows. The findings that I just reviewed with you confirm for the first time that limb events are likely thrombotic in nature and are potentially modifiable by antiplatelets and or antithrombotic agents. However, the effect of Vorapaxar on walking distance in patients with intermittent claudication remains unexplored. So we hypothesize that addition of Vorapaxar to daily background antiplatelet therapy, or APT, in patients with established PAD and intermittent claudication would lead to an improvement in patient symptom status with respect to their claudication. The objective and endpoints of the study include the primary trial objective, which is to evaluate whether addition of Vorapaxar 2.08 milligrams versus placebo on background antiplatelet therapy for 6 months to patients with peripheral artery disease and intermittent claudication treated with standard medical therapy, or SMT, would lead to an improvement in their peak walking time. The primary endpoint, therefore, is change from baseline to 6 months in peak walking time on a graded treadmill test per the Gardner protocol between participants enrolled in the test and control arms of the study. The secondary endpoints are change from baseline to 6 months in the claudication onset time on the GTT, or a Gardner protocol treadmill test, walking impairment questionnaire distance scores, or we refer to them as the WIQ scores, and self-reported quality of life score using the Medical Outcome Study 12-item short form survey, or the SF-12. There are a few tertiary endpoints, which are the first occurrence of A, clinically indicated lower extremity endovascular or surgical revascularization procedure, B, all-cause death, non-fatal myocardial infarction or ischemic stroke, and C is severe bleeding defined by the Guster classification during the entire study duration post-randomization. This is a multi-center, double-blind, phase 4 placebo-controlled randomized control trial. The study participants can be identified through referrals from primary care, ambulatory care, cardiovascular and vascular surgery clinics, referral from general internal medicine, hospitalists, cardiology and vascular services, or patient self-referrals to the research team or to providers participating in the clinical research study. Background antiplatelet therapy, I think this is an important one. All patients should have received at least 1 dose of 325 milligrams of aspirin if they have not been on chronic aspirin. That means they have not received any aspirin for the last 5 days. And if they have received or they are on chronic aspirin, that means they have received any dose of aspirin within the last 5 days. An additional 81 milligrams of dose prior to the study randomization would be considered as background antiplatelet therapy. Standard medical therapy, or SMT, is defined as the presence of any 2 of the following listed classes of agents: ACE inhibitors, angiotensin receptor blockers, statins, and beta blockers, and the ability to perform at least 15 minutes of walking a day, I repeat, in a complete day, at least 3 times per week at about greater than or equal to 20 steps per minute. I think this is important because we do want patients who are ambulating to some extent, and the minimal criteria are defined here. So it is important for the coordinators to pay attention and ask the patients carefully if they're able to walk multiple times a day, which would cumulatively be 15 minutes, and at a very comfortable pace, which is generally defined as 20 steps per minute. So the test arm of the study would be Vorapaxar, background antiplatelet therapy, and standard medical therapy. And the control arm would include placebo, background antiplatelet therapy, and standard medical therapy. Again, I repeat, this is a double-blind placebo-controlled trial. So to take you through the 4 key steps in getting the patients enrolled and follow up, and the time durations that one needs to be careful about. Pre-screening is the first step where you can go through patients' medical records. At this point, the patients are not consented, and the protocol allows pre-screening patients. Once you believe that the patients are most likely to be eligible or they fulfill the pre-screening criteria, you can then perform an informed consent and move on to the screening phase of the study. The word enrollment for the study protocol is defined by informed consent procedure for the patient. If the patients, after a full thorough screening, a screen fail, they need to be followed for an additional 7 days from the date of informed consent. All screening procedures need to be completed within 4 weeks of completion of the informed consent procedure. And patients who fail the pre-screening phase or are ineligible for moving on to screening, they can be re-pre-screened. What I have observed and what we have observed is that the most common reason for failure of pre-screening would be the fact that patients are taking additional anticoagulant or antiplatelet drugs in addition to what is approved for the study. And if that is the case, then the patients can be allowed a washout period. This pertains to patients, for example, who at the time of pre-screening are still completing their 12-month or 6 months as clinically indicated duration of dual antiplatelet therapy with clopidogrel, and after completion of the clopidogrel, if the clinical team wants to withdraw that antiplatelet drug or the P2Y12 inhibitor and leave the patient only on aspirin, then that patient could be pre-screened at a time duration following the washout period as indicated on the slide. The minimum duration of washout for the drugs are 14 days for warfarin and other anticoagulants and 7 days for ticagrelor, clopidogrel, prasugrel, teclopiridine, cilostazol, and pentoxifylline. I hope that is clear. After screening, the eligible patients can then move on to randomization, and from the completion of screening, randomization needs to be completed within a 2-week period. After completion of randomization, initiation of treatment can be within another week from completion of randomization, and this would allow you to mail the drug to the patient. Also, the patient, after completion of all screening procedures, may not need to come to the hospital for randomization. You could randomize him within the 2-week period, or randomize him when he's at the hospital for another visit within that window. And if the patient is not randomized on site, then you could mail the drug to the patient and allow 1 week for the drug to be delivered to the patient and treatment initiated at that point. As you may already know, that the follow-up duration is 6 months with a window of plus minus in 7 days from randomization to the end of follow-up. And there is also an additional phone call at 90 days. The pre-screening criteria are mentioned on this sheet. I will go through them in detail. I think this information is repeated multiple times during other slides. So the first criteria for pre-screening is that the patient should have a hemoglobin of greater than 9 and platelet count between 50,000 and 600,000. And these laboratory values could be in the last 1 year. No history of stroke or TIA. No allergy to aspirin, age greater than 40. The documentation of PAD is really important, as this has been inserted into the protocol and included so as to avoid patients who are pseudoclaudicants or have atypical features. And so the patient needs to have at least in one limb an ABI of grade of less than 0.8 or at rest, or a 20% drop with a claudication limited exercise ABI. And in addition, they need to have one of the following criteria. There has to be some anatomic definition of the disease in the lower extremities, either through documenting prior surgical or endovascular lower extremity intervention in the past, or a known flow limiting greater than 70% stenosis on a angiogram for clinical indication that has been performed earlier during cardiac catheterization, computed tomography, MRA, or duplex ultrasound criteria. Documentation of intermittent claudication of greater than 2 or more, Rutherford category 2 or more. As I said, the conditions that the patient should be on standard medical therapy, no MI or PCI with DES in the last 11 months. And again, I want to repeat here that if at the time of pre-screening they have a month of antiplatelet therapy to go, you could pre-screen them after a desired period of 7 days. No planned surgical or endovascular procedure for the treatment of intermittent claudication during the expected duration of the study. No warfarin or other oral anticoagulant used within the last 14 days. No use of antiplatelet drugs that are listed on the slide within the last 7 days. No contraindications to the use of antithrombin or antiplatelet therapies, like history of intracerebral hemorrhage or ICH, presence of intracerebral mass, recent or within last 12 weeks gastrointestinal bleed requiring blood transfusion, any blood transfusion within the last 6 weeks, any trauma requiring surgery within the last 4 weeks, or any surgical or endovascular procedure within the last 4 weeks. No use of cilastazole or pentoxifylline within the last 7 days. Severe psychiatric or behavioral illnesses that, in the judgment of the investigator, would preclude study participation. No history of major or minor lower extremity amputation. Severe heart, vascular, and lung disease which at the discretion of the operator would preclude this patient from performing exercise tests and hence participation in the study. And finally, the patient should be able to walk a cumulative duration of 15 minutes per day, at least 3 times a week, and at a rate of greater than or equal to 20 steps per minute. Now, I would remind you that after the pre-screening phase is completed, you have to then move on to screening after informed consent completion, and all the screening procedures listed here need to be completed within a 4-week period from informed consent. A 2-week monitored home walking regimen. Again, the patient has to document how much he has been walking. History and physical, and a exercise treadmill test as per the Gardner protocol. Again, the Gardner protocol is a low-level exercise treadmill test, which is the details of which are included in the supporting documents. The patient needs to perform at least 2 tests, so at least 1 hour apart from each other. And if the peak walking times are within 30% of each other, then just take the longer of the 2 durations. If these 2 durations of time are greater than 30% from each other, then a third GGT needs to be performed, and the highest of all the GGTs will then be considered as baseline value. Laboratory values within the last 1 year, again, hemoglobin greater than 9, platelet count greater than 50,000 or less than 600,000, recording of ankle brachial indices, a WIQ score, and a SF-12 questionnaire needs to be completed. After screening procedures are performed and the patient is eligible, you move on to randomization. This needs to be performed within 2-week period from end of screening procedures. Again, randomization is 1-to-1, and the inclusion criteria and exclusion criteria for prior to randomization are shown on the slide, and these are no different. Again, that peak walking time has to be between 2 and 10 minutes on the Gardner protocol. We don't want patients who absolutely cannot walk or can walk a distance that would indicate that they don't have severe claudication. So estimated survival of greater than 1 year at the judgment of the investigator. Again, the criteria for baseline antiplatelet therapy use or aspirin use. As I've already mentioned, baseline use of standard medical therapy. Exclusions, recent MI or PCI within the last 11 months, positive pregnancy test for women, planned surgical or endovascular procedures for the treatment of intermittent glycation, again contraindicated drugs, antiplatelet drugs and anticoagulants, as I mentioned before, and also contraindications with respect to the use of antithrombin and antiplatelet drugs, as I've already repeated in the prior slides. So again, from randomization to initiation of treatment, you have 7 days. It will give you enough time to meet the drug. For study protocol, follow-up is for 6 months. The trial will be considered complete with regard to the primary endpoint after all enrolled subjects have completed a 6-month follow-up evaluation or have passed, have a documented premature withdrawal, or whose follow-up window at 6 months is closed with documented 3 unsuccessful attempts to contact the patient. Patients who discontinue study medication should be followed till the end of the study. Adherence to monitored home walking for 1 week will be assessed in all patients in each arm at 3 month plus minus 7 days from randomization by a phone follow-up. A follow-up phone call by a study coordinator has to be at around 90 days plus minus 7 days to reinforce the monitored home walking by reviewing what they have written on their diary, a compliance with study and clinically indicated medications, and determine study-related adverse or severe adverse events or other pertinent medical history. End of the study testing at 6 months from randomization should be performed within a window of 7 days, plus minus, from the scheduled date, and should include a GTT, H&P, WIQ, and SF-12 questionnaire and a study drug pill count. Patients will be required to return all study drug bottles and remaining study drug pills at the end of the study. At the end of the study, the patient will also undergo the GTT exactly as per the same regimen as described during the baseline testing. Patients who are pre-screened will be recorded. Those who are then eligible for screening and undergo successful screening procedures, however not randomized, will be termed as screen failures. Participants who discontinue study medication by withdrawing consent following randomization will be termed as dropouts. As I also want to mention that there may be situations where patients who are on aspirin and they are on the study drug and now require, for clinically indicated reasons, the addition of another antiplatelet agent. At that time, if an antiplatelet drug needs to be used, and if the investigators and sites are encouraged to use clopidogrel. However, if there is the situation where other drugs absolutely need to be used and like anticoagulants like warfarin and others, the study drug could be held, but the patient needs to continue to follow in the study, and if for some reason the use of the drug is temporary, the study drug could be reinitiated after the desired washout period as described earlier. A full table showing all the different kinds of pre-screening, screening, randomization, follow-up visits and tasks are listed on this sheet. Please go over this and review review this table, and if there are any questions, please don't hesitate to call us. The study sample size requires 200 patients. There are going to be up to 220 US sites. Expected randomization will be approximately 1.7 to 2 patients per month. There is an IMedNet online data management portal where all the data needs to be entered. Rigorous follow-up to avoid dropout and perform only clinically necessary vascularization is highly encouraged. HIPAA authorization in addition to ICF where necessary as per your IRB requirements. There will be monthly teleconferences till completion of recruitment, and then Q2 months thereafter, and coordinating sites, and will have our business and emergency contact numbers in case you need to reach out to us for any reason at the Central Study Chair's office. An adverse event and serious adverse events, the AE and SAE, will be collected and reported to the local IRB and study coordinating center IRB from enrollment to completion. Causal relationship to the observed AE and SAEs to the study drug will also be collected and reported. There is a data safety monitoring board which is independent, will review all AEs and SAEs. Risk-based monitoring is being employed for this study, and we have certain criteria that we will use to determine which sites need more than one visit, and we at least will have one visit for 75% of the enrolling sites. As I mentioned, there will be an independent DSMB and also an independent CEC for the study. Study drug handling. All study drugs, active drug, matched placebo must be accounted for and tracked on a paper log provided for the study. From time of initial receipt through dispensation and final disposal or return of leftover study drug, accountability logs should indicate the date received and dispensed, kit numbers and amount dispensed to the participant, amounts and condition of material returned, destroyed, disposed by the participant. Prior to dispensing, the PI at study site pharmacist or study coordinator trained on the study protocol will be responsible for ensuring that the participant has been properly consented, enrolled, instructed, and a written prescription order for the drug is signed by the PI. Unblinding. Unblinding of participant treatment assignment can be made by calling the coordinating center business and emergency phone numbers, which are included in your protocol. And again, please use your clinical judgment, as I mentioned, if patients during the study require or suffer AEs, SAEs, or require additional drugs that are relatively or contraindicated for the use of any one of the study drugs. Good clinical practice requirements for the study. The PI commitments and investigator qualifications agreements are reviewed here, properly qualified to assume the responsibility for conduct of the study. The PI should be thoroughly familiar with the investigational product and its appropriate use, willing to comply with GCP and applicable regulations, and prepared for audits and monitoring, and maintain a delegation log for responsibilities assigned. The PI commitments and the study team should ensure that all trial-related medical decisions are made by an investigator who is a qualified physician. Provide adequate medical care for participants who experience adverse events. Notify the participant's primary physician or his or her participation as appropriate. Make an appropriate effort to learn why participants withdraw from the study. Also, obtain written approval before the study begins. Provide the IRB with current package inserts, and provide the IRB and IEC at your sites with all documentations subject to its review throughout the trial. With respects to compliance with the protocol, conduct the trial in compliance with the criteria in the protocol. Deviate only with agreement from the sponsor and prior review, approval from the IRB or IEC, or unless medically necessary to provide clinically indicated patient care. This is really important. And document and explain all deviations. In terms of the investigational product, the PI commits to be responsible for the product, its usage, and its storage. May delegate to a pharmacist under the PI's supervision. Maintain records. Store as specified by the sponsor, and it's in accordance with applicable regulatory requirements, and use investigational product in accordance with the protocol only. In terms of randomization and unblinding, we have gone over that, but follow the study randomization procedures. Ensure that the randomization code is only broken in accordance with the protocol, and promptly document and notify the sponsor or the central committee at Dallas VA Medical Center for any unblinding that undergoes in the study. In terms of informed consent, you're asked to adhere to the GCP and the ethical principles that have their origin in the Declaration of Helsinki. Update the consent document when new information becomes available. Avoid coercion or undue influence, language that causes the participants to waive any legal rights. Fully inform participants of all pertinent aspects of the trial, and use understandable language at the 8th grade level when communicating with the patient. Provide enough time for participants to review consent and ask questions. Other essential elements for the informed consent include the number of subjects involved in the study, description of risks, benefits, and alternatives, information about compensation, care for injury, statement regarding confidentiality of records, description of possible unforeseen risks, circumstances for termination without subject consent, consequences of withdrawing from the study, statement that new research findings will be shared, and contact information for questions and concerns. With respect to records and reports, all changes to the CRF source documents must be dated and signed such that the original data is not obscured. Retain essential documents for at least 2 years after the last approval of a marketing application. Provide monitors, auditors, IRB and IEC, or regulatory authorities with direct access to the trial records. Record and report AE and SAEs thoroughly. Make records available to monitors, auditors, and inspectors. Longest requirements should be followed for the record retention if study or institutional requirements vary. Essential documents, there are many others, but these are some of the key ones. Investigator of record, CVs for PIs and sub-investigators, licenses as appropriate, training records for all study personnel, protocol amendment, signature page, and financial disclosures, IRB membership list or roster, IRB approvals, protocol consents, ads and handouts, communication with IRB sponsors whenever applicable. All progress reports to the sponsor, IRB and IEC, need to be submitted as a written report at least annually and in accordance with your local IRB requirements. Submit a written report if there are changes that might significantly change the conduct of the trial and or increase the risk of the subjects. With respect to safety reporting, immediately report all SAEs to the sponsor, which is the Dallas VA Research Corporation. Follow up with a written report. Exceptions are SAEs identified in protocol as not requiring immediate reporting. Identify study subjects using codes rather than personal identifiers, and comply with applicable regulatory requirements related to the reporting of unexpected serious adverse drug reactions to the regulatory authorities and the IRB and Study Coordinating Center. Report AEs and SAEs and or lab abnormalities critical to safety evaluations to the Coordinating Center for Protocol. Provide the sponsor and IRB with additional requested information. Autopsy report in the event of death and EKG or other supporting documentation when necessary. Premature termination or suspension of study. The conditions and who to notify are listed on this slide. Please take a careful look at it. Most of the time you have to inform the institutional IRB, the sponsor, and the institution where the study is being conducted. And study terminated and suspended, all participants also need to be informed about. At study completion, the investigator should provide the documentation again listed on the slide, a notification of study completion, summary of the trial outcome, and any other required reports that be needed for audit purposes and for completing reports. Examples of common non-compliance are mentioned here, which may include insufficient evidence of investigator involvement or oversight, no documented delegation of responsibility and scope of work, failure to adhere to protocol requirements, inadequate source documents, changes made to original records without audit trail of when, why, or by whom, failure to report A's and SA's appropriately or in a timely fashion, participants not signing most current version of the consent form, and an inadequate product accountability records, the investigational drug. Of course, this is by no means a complete synopsis of all the requirements for good clinical practice, but these following links and resources would be of help, and if you need additional information, please don't hesitate to contact us. I thank you again all for joining and going through the TRACE study protocol training. Thank you very much.